Hello everyone and welcome to our module on AVNRT. AVNRT is a cardiac arrhythmia, but before we talk about that, let's talk about a more general topic, and that is the topic of PSVTs. A PSVT is a paroxysmal supraventricular tachycardia, and each of the words in the name means something about the disorder. So these disorders are tachycardias, where patients develop intermittent fast heart rates greater than 100 beats per minute. The disorders have a sudden onset or offset. That's why they're called paroxysmal. A paroxysm is something that comes on suddenly. So these tachycardias abruptly occur in contrast with sinus tachycardia. So for example, if you're going to develop a sinus tachycardia from jogging, your heart rate will gradually rise from a low level of 60 or 70 beats per minute at rest to a fast heart rate of 120 or 140 beats per minute. That is the opposite of what happens in a PSVT, where the heart rate goes abruptly from 60 beats per minute or so to 150 beats per minute, for example, a very sudden onset and offset. And this sudden onset and offset, as we will describe in a minute, causes palpitations. The reason these disorders are called supraventricular is because the origin of the electrical activity is above the ventricle, or supraventricular. And this is in contrast with ventricular tachycardias, where the origin of the electrical activity is in the ventricular myocytes themselves. And because the origin of the electrical activity is above the ventricle, electrical impulses still travel through the normal AV node, His bundle, bundle branches, and Purkinje fibers, and therefore the QRS complex is normal or narrow at less than 120 beats per minute. So shown on the screen here is an example of what a PSVT looks like on ECG. You can see that the QRS complexes are close together. The heart rate in this tracing is about 150 beats per minute or so. You can see that the QRS complexes are narrow. They are less than 120 milliseconds. Therefore, this is a narrow complex tachycardia. And if this were to occur suddenly in a patient, we would then call it a PSVT. And as I mentioned on the last slide, the problem with these disorders is that they cause sudden onset palpitations. So most patients will say, I was sitting at rest and suddenly I felt my heart racing for a few minutes and then it broke. That's the typical history of a patient with a PSVT. Sometimes these patients also have chest discomfort, and rarely, if the tachycardia is very, very fast, it can lead to syncope. There are many causes of PSVTs, but the most common is AVNRT, which stands for atrioventricular nodal reentrant tachycardia. This is a tachycardia that involves the AV node. That's why the words AV are in the name. It's common in women, usually younger women. About 32 years of age is the mean age of onset. So a patient like this will commonly present to her physician complaining of intermittent fast heart rate and palpitations. That woman may have a PSVT, and most likely she has AVNRT. And in order to have this tachycardia, there has to be something present in the AV node called dual AV nodal pathways. So let's talk about that now. So recall that in normal impulse conduction in the heart, impulses are generated by the SA node. They then travel through the AV node to reach the His bundle, the bundle branches, and the Purkinje fibers, and to depolarize the ventricles. In normal patients, all of the cells found in the AV node conduct electrical impulses at approximately the same speed. However, in patients with AVNRT, they have what's known as dual pathways in their AV node. This means that some cells in their AV node conduct electrical impulses slowly, and other cells in their AV node conduct electrical impulses quickly or fast. These patients are said to have dual pathways because there is a slow pathway for electricity through the AV node and also a fast pathway. Now, the slow pathway cells tend to have a short refractory period. It means that although they conduct impulses relatively slowly, after they conduct that impulse, they very quickly are ready to depolarize again. The fast pathway cells are the opposite. Even though they conduct electricity very quickly, they have a long refractory period, and it takes them a long time to be ready to conduct again. Now, when patients are in normal sinus rhythm, there are no consequence of these two pathways. That's because what happens is what's shown on the screen here. The slow pathway slowly conducts electricity down the slow pathway. The fast pathway rapidly conducts impulses, and when those impulses reach the His bundle, they depolarize the His bundle in the ventricle. They also begin to send electrical impulses back up the slow pathway, and the impulses coming down and going up meet each other and cancel each other out. So under normal circumstances, when patients with dual pathways are in normal sinus rhythm, they are conducting impulses only down the fast, and they have no idea that they have dual pathways. Now consider what happens to a patient with dual pathways if a PAC occurs, or a premature atrial contraction. Remember that the fast pathway has a long refractory period, so if a premature atrial depolarization occurs, it may encounter the fast pathway when it is refractory and cannot conduct electricity. In this situation, impulses will travel down the slow pathway, and because the slow pathway is slow, by the time those impulses reach the bottom of the AV node, the fast pathway will be ready to conduct an impulse again. We can now have a circuit generated where impulses are going up the fast pathway and down the slow pathway and rapidly depolarizing the His bundle and the ventricles. This will create a tachycardia that is not originating in the SA node like normal electrical activity. Instead, there is a circuit inside the AV node causing the tachycardia, and this is called AV nodal reentrant tachycardia. Importantly, it requires dual pathways and it requires a PAC to get the arrhythmia going. The hallmark of AV-NRT on the ECG is the presence of a narrow complex sudden onset tachycardia and also the presence of retrograde P waves. Shown here with the arrow is a retrograde P wave. So remember that you have a circuit going around the AV node. When that circuit reaches the top of the AV node, it can send an impulse retrograde or backwards to depolarize the atria. That creates a retrograde P wave that comes after the QRS complex, not before, and these are seen in every beat on the ECG in patients with AV-NRT. So patients with AV-NRT and dual pathways in their AV node develop recurrent episodes of palpitations when their heart suddenly begins beating very fast. Many times the arrhythmia spontaneously breaks and the palpitations resolve. However, if the tachycardia does not break, you can break it yourself by doing something that decreases conduction in the AV node. This will stop the arrhythmia. When you slow conduction in the AV node, usually you will halt conduction in the slow pathway. Remember, the slow pathway is already slow, and if you decrease the conduction velocity further, usually the slow pathway stops conducting electricity and that breaks the circuit. And there are three main ways to slow conduction in the AV node to break AV-NRT. The first is carotid massage, which we'll talk about in a minute. The second is vagal maneuvers, which we'll also talk about in a minute. And finally, the drug adenosine slows conduction through the AV node. And I talk about adenosine in more detail in the video on antiarrhythmic drugs. So carotid massage is something that a physician can do to a patient at the bedside. The examiner presses on the patient's neck near the carotid sinus, and what this does is it stretches baroreceptors in the carotid sinus. This will trick the central nervous system into thinking that blood pressure is high, and the CNS will respond via the autonomic nervous system as if there's high blood pressure. And one of the responses to high blood pressure is to increase vagal tone, which slows conduction in the AV node. So I've done this in the emergency room on patients who have AV-NRT. I press on their neck, and after a minute or so of pressing, the arrhythmia breaks and the palpitations go away. Another way to slow conduction in the AV node is to ask the patient to perform what are known as vagal maneuvers. These are maneuvers that increase the output of the vagal nerve, and therefore they lead to slowing of the heart rate and slowing of conduction through the AV node. And the classic vagal maneuver is the Valsalva maneuver. The Valsalva maneuver is where a patient bears down as if they are trying to move their bowels. What this does is it increases the pressure inside the thorax, and that slightly increases the pressure in the aorta. When this happens, baroreceptors sense this rise in pressure, and through reflexes, they slow the heart rate and slow conduction through the AV node, and this can break AV-NRT. And in the video on heart murmurs, I also talk about the Valsalva maneuver because in addition to increasing the pressure in the aorta, it also decreases the preload, and that can alter the sounds of a particular heart murmur. In addition to the Valsalva maneuver, there are a number of other vagal maneuvers. Some of them include holding your breath, coughing, taking a deep breath or deep respirations, gagging, or swallowing. And many patients who have AV-NRT learn to do these maneuvers so that when they begin to feel palpitations, they can break the arrhythmia. There are a number of treatment options available for patients with AV-NRT. Many patients have infrequent symptoms and they require no therapy at all. Other patients can be placed on beta blockers or calcium channel blockers like verapamil and diltiazem. These drugs slow conduction in the slow pathway, and they often prevent the arrhythmia from occurring. And then finally, for patients with very frequent symptoms, there is a surgical procedure to ablate the slow pathway, and this can make the arrhythmia permanently go away. And that concludes our video on AV-NRT.